I'm George Wilson. I was fortunate to be invited to give this talk last year or the year before, so I'm very happy to be here again and give this talk to you. Just a little bit of background is that I'm a real radiobiologist. I trained at the Gray Laboratory in London, and of course, the Gray Laboratory was founded by Hal Gray, and as you all know, his name is the unit dose of radiation, so a very famous radiobiology lab. I'm over here in America now, working in Michigan at Beaumont Hospital, but actually also at Henry Ford now. So this is a lecture which I'm going to try and explain, why we would use BED, biologically effective dose, and EQD2, equivalent dose in 2 gray, to compare different schedules and particularly how relevant it is to hypofractionation. So this is the outline of today's talk. We're going to talk about the BED concept, where it derived from, how you get the numbers from it. We're going to talk about the equivalent dose in 2 gray. And then we're going to talk about how you can use them together, how they can complement each other with the information that you can get from them. We're going to talk a little bit about the limitations of the linear quadratic model. I hope you all know about linear quadratic model. We'll talk a little bit about that. And how it may not be as effective for hypofractionation and SBRT. And then we're going to finish off with some clinical examples, real clinical examples of BED and EQD2 in hypofractionation schedules. So this is the first part of the talk, and we're talking about the BED concept. I'm going to tell you how it came about. We're going to see how the formulas are derived, and then we're going to find some of the ways of using it, looking at isoeffective fractionation schedules, calculating dose constraints for normal tissues, and assessing safety of fractionation schedules. So this is just a little bit about the history. The biologically effective dose was first mentioned in 1989, and actually by this review down here by Jack Fowler. Jack Fowler actually was the director of the Gray Laboratory when I was there. He's a very famous radiobiologist. And he was the first to coin this biologically effective dose. And it's important that you know it's effective dose. It's not equivalent dose. It's not the real dose that's being delivered to a tissue. It's the effective dose based on the response of that tissue. And it replaced some of the old concepts which were still around. One was called the nominal standard dose, other was called the time dose. And these were trying to relate total dose and overall treatment time and number of fractions, but really didn't fit the data very well. So the BED concept was taken really from some earlier work by a very famous radiation oncologist from the Netherlands called Eddie Baronson. And the concept was it's a dose that would cause the same log cell kill as the schedule under consideration if it was delivered in infinitely small fractions, spaced out, or at a very infinitely low dose rate. So what does that mean? I read this next slide, I'll just explain that. So here we have some survival curves, a single dose, 2 fractions, 5, 10, and you can see that every time you fractionate, you're really recapitulating or repeating the shoulder of that survival curve. So the concept of the BED is that if you gave an infinite number of small fractions, you would get a line like this, which would eventually cross an effect level, and often it's 10 to the minus 10 log cell kill. And this would then be the biologically effective dose. And in this instance, I just need to move this camera out of the way a little bit so I can read my slides. In this instance, what happens is that the dose becomes very, very small. The number of fractions has to be increased. The beta d squared part of this is a standard equation for calculating cell survival or effect, is n alpha d plus beta d squared. This is from the linear quadratic. The beta d squared becomes infinitely small and so can be ignored. And so in this particular case here, then the effect, in this case it's log cell kill, equals number of fractions, the alpha component, and the dose per fraction. And so n and d can be combined so that the effect simply equals alpha d. And so thus the total dose d of radiotherapy given at very low dose per fraction is the highest total dose required to obtain a specific effect. Sorry. So when we take this into um, how we could use this, why we would use this. So this is a definition of biologically effective dose. It's a measure of the true biological dose delivered by a particular combination of dose per fraction and total dose to a particular tissue characterized by a specific alpha beta ratio. Now, we haven't really talked about alpha beta ratios yet, but this is a derivation from the linear quadratic model where the effect of the alpha and the beta component are equal at a particular dose. And what we know is that the alpha beta ratio differs for different types of tissues. So late responding normal tissues have a very steep, bendy survival curve. The alpha beta ratio is low. For rapidly dividing normal tissues like oral mucosa, the alpha beta ratio is much higher because the curve is not so bendy. So it's really taking in account of the shape of the cell survival curve and the sensitivity of that tissue to radiation. And so the BED, as you'll see, is very useful when we're trying to look at isoeffective dose calculations, comparing two different schedules, simple fractionation changes, corrections of errors, uh, changing in the overall treatment time, gaps in treatment, and then also converting the BED to the equivalent dose in 2 gray fractions. So we'll see examples of all of these. This mouse is very sensitive, sorry. So the BED for any practical radiotherapy schedule can be dividing both sides of the equation. So this is the standard equation we saw on the previous slide. E equals N times alpha D plus beta D squared. Divide it by alpha. So here, BED equals E over alpha. E is this component here, and this is alpha. When we divide by alpha, we then reduce this formula. So BED equals the number of fractions, the dose per fraction, and then 1 plus the dose per fraction divided by the alpha beta ratio of that particular tissue or tumor. So this is a standard BED calculation. We could obviously just reduce ND, number of fractions, and dose per fraction to just total dose. And so again, this is the standard BED formula derived from this calculation. And when the alpha beta ratio is small, less than 3 gray, for instance, that's characteristic of a late responding normal tissue. In late responding normal tissues, the overall treatment time is not really an issue because they don't respond until after the treatment's finished. And so this is the simple calculation that you can use for any late responding normal tissue or tumors even, such as prostate, where the alpha beta ratio is low and they're slowly proliferating. If there is an issue with proliferation or repopulation, then we have to modify this simple BED calculation. And here you can see how it's modified in 2 different ways. If there is proliferation occurring during treatment, and what that means is that there are more cells being produced, meaning that there's more clonogenic cells to kill. And so the dose that you're giving will not be as effective as if there was no proliferation. And so you actually lose dose per day. And this is this parameter K. It's basically the daily BED equivalent of repopulation, of growth that's occurring, and T is the overall treatment time. And so in this calculation, it's assuming that repopulation is continuous from the start of treatment. And it has been shown that doses as much as 0.5 to 0.9 gray per day can actually be lost due to this proliferation during treatment, particularly in head and neck cancer. This isn't the physical dose, it's the biologically effective dose that's being lost each day. Another alteration of the basic formula is that it's been shown in some tumors, and again, head and neck are one example, that repopulation doesn't actually kick in until a certain time during the treatment. After that time, there is accelerated repopulation. And so again, this whole BED formula can be modified, include this lag phase, TK, before proliferation kicks in. And so again, both of these examples, because of proliferation, repopulation, you're losing dose per day. And so the biologically effective dose isn't as effective as it would be for, say, a late responding normal tissue. So again, these are just various nuances of the BED concept to allow for proliferation. So BED really depends on dose, dose per fraction, and the alpha beta ratio. And so here we've got ED values for the same dose, 60 gray. We have different alpha beta ratios, 3, 5, 10, 15. So late responding through to early responding in tumors. And then we've got different fraction sizes, 2, 3, and 4 gray. The total dose is the same, 60 gray. So you can see that when the alpha beta ratio is low, and these types of tissues are much more sensitive to changes in dose per fraction. You can see that the biologically effective dose goes up in increments of 20 gray for these late responding normal tissues. However, for a early responding normal tissue or for tumors where the alpha beta ratio is high, you can see that the dose increment is not as great. They're not as sensitive to the fractionation or the change in fractionation as late responding normal tissues. And it is a key issue that we'll need to talk about. And one of the reasons why BED is very effective to really look at organs at risk, particularly late responding organs. They're much more sensitive to changes in fractionation, and therefore much more biologically effective dose goes in to that tissue as you increase dose per fraction. Really, this is what I've just said here. And one of the things that we do with BED is that we usually write it with a subscript, and that subscript is really the alpha beta value. So for early complications, it would be in gray 10. For late complications, it would be in gray 3. And some tissues like spinal cord, heart, and it's even lower at gray 2. So again, there are different alpha beta values for different normal tissues and tumors. Although in general, we can't really measure it for each individual tissue and tumor. And so we tend to make assumptions of a value for that particular tissue or tumor. If you look combining EBR, external beam, and high dose rate brachy, then you will just combine ED for both of those components, and we'll see an example of that. So again, this is just showing you that for the same total dose, the BED will change based on fraction size and alpha beta ratio. So one of the key things of using a biologically effective dose is really to look at isoeffective fractionation schedules. So what if I changed total doses, but I want to achieve the same biological effective dose? And so the BED formulation is actually a nice way of being able to compare two different schedules, which are giving two different fraction sizes, and to see whether they're isoeffective or not. So here's an example where we're going to change the fractionation schedule. So we have a critical normal tissue that's got an alpha beta ratio of 3 gray. So it's a late responding normal tissue. It's getting a maximum dose constraint of 60 gray in 30 fractions. Well, what we would now want to know is what would be the equivalent maximum dose constraint if we gave it in 20 fractions instead of 30 fractions. So now we're going to try and work out what that dose per fraction would be. Here it's obviously 2 gray, but now we're giving less fractions, so the dose will be higher. And so again, this would be the simple formula. We have D1, which would be the 60 gray in 30 fractions, and now we're going to calculate what D2, little d2 is here. So first of all, we would calculate what is the BED for this standard fractionation. So simply, it would be 30 times 2 gray times 1 plus 2 gray per fraction divided by the alpha beta ratio. And so we now get this, that it's 100 gray 3. So now what we wanted to do is calculate what that dose per fraction would be for 20 fractions to give us the same total BED. So this again would be the formula. Now again, this is where you have to sort of believe me, and we're now going to this formula can actually be rearranged to set everything equal to 0, and this would actually then give this formula. And then this formula can be arranged to a quadratic equation. And so this is the standard quadratic equation. And we would then substitute in these values into the quadratic equation. So in this case, A in the quadratic would be 6.67. B in the quadratic would be 20, the number of fractions. And then C in the quadratic would be 100. So this is one of the tough things about doing BEDs by hand, and I recommend everyone to download some free calculators, which I'll tell you about at the end of the talk. However, when you solve this quadratic equation with these parameters, then the solution is B, the dose per fraction, would now be 2.65. And so the total dose would be 20 fractions of 2.65, and that would equal 53 gray. Again, what it's showing you is how you calculate an isoeffective schedule based on a standard schedule, or this could be any schedule, so you're comparing it to. So again, this is the complex part of the BED, is solving these equations. Down here, I can't read it because something's in the way. What would be the equivalent for 15 fractions? And again, you would go through the same analysis, 15 fractions in here, and then you would get 3.22 gray, giving you a total dose of 48.3 gray.
Dr. Wilson, I have a question for you. So it's Maria. So I have a question, and this is something that has come up in the chat. So for the alpha beta of certain tissues or tumors, do you have like a reference document that you use? Because one of the things that we've done with using hypofractionation is that we know that there are certain types of tumor that have lower alpha beta, let's say prostate cancer, let's say the breast. So do you have like a reference document for those alpha beta values?
Yeah, not personally. There was a review which was published a couple of years ago, which summarized all the alpha beta values that they could find in the literature for tumors. So I can share that reference with you after the talk, and you can distribute that. But in general, the tumors which have low alpha beta ratios, the prostate obviously is the prime example, could be as low as 1.5. Breast is about 3.5. Melanoma, again, around 3. And one or two others. But most tumors, certainly most adenocarcinomas, most squamous cell carcinomas, have high alpha beta ratios. And so in general, 10 is used for virtually all, though more rapidly proliferating tumors. But some of those could be even higher. It's been thought that maybe 20 gray for some of the head and neck cancers and maybe lung cancer. And then you see at the end of the talk that changing the alpha beta ratio can really change the data that you get. So it's probably the weakest part of the whole concept, because we can't measure it individually in each tumor. We have to make an assumption about that.
Okay, great. Thank you so much.
Okay. That is now looking at toxicity analysis. So here we have an example of, we're treating a target to 26 gray and 5 fractions, and we're worried about the normal tissue reactions. And so we're going to calculate what the BED is for a early responding normal tissue with an alpha beta of 10 gray, so something like mucosa. And we want to know what dose in 5 fractions is equivalent to a conventional schedule of 50 fractions in 50 gray in 25 fractions, 2 gray per fraction. Again, we've got a hypofractionated schedule, and we want to really see, what's the equivalent in a more conventional schedule. And so here we are. The calculation would be this. We have one schedule here. This is a 25 fractions in 2 gray. And then we have 5 fractions. And now we're trying to calculate what this dose would be in the 5 fraction schedule to be equivalent to this more conventional schedule. So again, these equations can be rearranged. And again, the alpha beta ratio is going to be 10. So we alpha beta ratio 10 in here. And then this equation can be solved, and it will give us this value, 5d2 squared plus 50d2 minus 600. And then just solving that gives you the actual dose of this schedule. 7 gray would give you the same effect in 5 fractions as 25 fractions of 2 gray. And so now 5 times 7 gray equals 35 gray. And so again, it shows that we are we're actually giving much less dose than we would give with a conventional schedule for this early responding normal tissue. It would be 35 gray, would give us the same effect as 25 fractions of 2 gray, but we're only giving 5 fractions of 26 gray. So again, what we know here is that we're not really going to be causing any extra damage to this tissue. What about if it's a late responding normal tissue, and the alpha beta is now 3 gray rather than 10 gray? So what would then be the dose that we're giving that late responding normal tissue? Exactly the same, 5 fractions, total 26 gray. So again, we put these numbers into the calculation. Now the alpha beta value is going to be 3. And when we solve the equation again, we end up with this dose is now 5.73 gray. And so now 5 fractions of 5.73 gray would equal 28.6 gray, which means that really now we're getting closer to the dose that we're actually delivering. And so again, it's not greater than this 26 gray, but it's much closer. Again, showing you that these late responding normal tissues are more sensitive to these hypofractionated schedules because of this low alpha beta value and because of their shape of their survival curve. So this is the first Zoom poll. Alejandro, shall I read the question out?
Yes, of course. Now everyone is having the Zoom poll in their screen, but please, you can read it.
So the question is, which of the following fractionation schedules would likely produce the highest incidence of late normal tissue toxicity, assuming an alpha beta of 2 gray for this critical normal tissue? So you've got 4 schedules there, 24 gray and 6 fractions, 50 gray and 25, 45 gray and 9, and 60 and 60. And also they're also in different overall treatment times. So I know you haven't got the calculators handy, so you really just got to think about the concept. Again, a late responding normal tissue is going to be much more sensitive to hypofractionation and isn't going to be as sensitive to overall treatment time.
Okay, I think 10 seconds more to the people. Vamos a dar 10 minutos adicionales para que respondan. Los invitamos a todos los participantes a participar de este Zoom poll y mirar cómo vamos con la sesión de hoy y los conceptos que estamos aprendiendo. There are a lot of people just answering, so I will give a little bit more time, like 10 seconds more. Okay, 2, 1, let's go.
Well, there's a few answers. The majority have gone for A, and then followed by C, B, and then D. So the answer is actually C. So the reason that it's C is that because we're looking at a late responding normal tissue, and late effects are not really affected by overall treatment time. And so these short treatment times actually don't make much difference. It's the total dose which is most important. And if we actually did calculate the biologically effective doses for each of these different fractionation schemes, we would get 72 gray for A, 100 gray for B, 158 for C, and then 90 gray 2 for D. And so really it's this protocol of 45 gray in 9 fractions that results in the greatest BED, and then is likely to produce more late normal tissue complications. So the important thing is that it shows that fraction size and total dose really play important roles to determine the probability of late effects.
Thanks, George. Thanks for that question. I think it makes us a lot of think about it. Also, I have a participant who asked a question that I will him to speak to you. Alejandro Blanco, voy a darte micrófono para que puedas hacer la pregunta que hiciste en el chat. A ver, acá. Creo que... Alejandro, adelante, ya tienes micrófono para hablar.
Gracias y buen día a todos. En los últimos tiempos se habla en español, ¿no?
Sí.
En los últimos tiempos se habla de un impacto muy importante de la tasa de dosis en tratamientos cortos como la radiocirugía. Entonces, en tratamientos de radio que duren más de 1 hora, algunas BED es diferente. Entonces, quiero conocer la opinión del profesor con respecto a eso.
George, I think you heard the question in Spanish, so I will try to translate.
Thank you.
Alejandro is asking about the dose rate for radiosurgery, because what is the effect if the dose rate of the treatment is delivered in less than 1 hour or is delivered in more than 1 hour? Alejandro, no sé si esa es la pregunta.
You know, dose rate, we haven't really gone into that, but dose rate does affect the biologically effective dose. And that's because of repair during those longer delivery times. And so 1 hour may not be a massive problem. There will be repair of sublethal damage going on during the delivery of the treatment. Whereas with normal fractionation, where you deliver it in half an hour or whatever, it doesn't happen. And so if there's repair going on, then the biologically effective dose gets reduced slightly because of that repair during the treatment. And so there is another formula, which I didn't show because I didn't think we were going to talk about dose rate, where you can allow for that incomplete repair in the schedule. So dose rate will affect the biologically effective dose, and it's really due to repair of sublethal damage.
Thank you, George. Go ahead.
So moving on, we're going to talk now about the equivalent dose in 2 gray fractions and give some examples of that. So again, remember that the BED is the effective dose, but now what we're trying to do with the equivalent dose is to translate a new schedule back to what it would be in 2 gray fraction. And you know, the reason that we do that is that literally all of the tolerance data to normal tissues was developed back in the 70s and 80s when the standard dose per fraction was 2 gray. And so we have a lot of clinical knowledge about the response of different normal tissues and also partial volume responses at 2 gray per fraction. And so for clinicians, you know, this equivalent dose in 2 gray is more familiar, it's more practical, and it's easier to interpret. But again, it's not telling you the actual effective dose that tissue is giving. So this is the linear quadratic, again, is used to measure the equivalent dose in 2 gray. So this is the standard equation. So here we have the 2 gray dose, again, all linear quadratic depends on the alpha beta. And so it's the new fractionation schedule dose per fraction, plus the alpha beta divided by 2 gray, plus the alpha beta, and then times the total dose. It'll convert any schedule back to 2 gray per fraction. And so this is just an example of it, and it's a good example. We've got a patient with metastatic bone pain, and that patient is being considered for palliative radiotherapy. And so we're actually going to give 4 times 5 gray. Really, what we want to know is what is this 4 times 5 gray as an isoeffective dose in 2 gray per fractions for the spinal cord, because we're worried about the tolerance of the spinal cord. First, you have to choose the alpha beta. Again, there's a lot of data suggesting that the alpha beta ratio for spinal cord is 2 gray. And so we're going to insert this into this equation. So the total dose is going to be 4 times 5, 20 gray. This is our 5 gray per fraction, which is the alpha beta ratio. And we're now dividing it by the 2 gray per fraction and the alpha beta ratio. And again, solving this would give us 35 gray. So 20 gray delivered in 5 fractions is biologically equivalent to 35 gray in 2 gray fractions with this alpha beta of 2 for the spinal cord. So again, it's telling us that, again, this is probably just under tolerance for that spinal cord. You can see it's really a different way of using the equivalent dose in 2 gray. Really, it's relating a change in the fractionation to something people are much more comfortable with, which is what is that? What would that be in a conventional 2 gray per fraction schedule? This is another example, a little bit more complicated, but it's really trying to find out that if we do a little bit of acceleration, this is DeHanke. DeHanke is the Danish head and neck cancer cooperative group who've been doing clinical trials for years, and they always do sequential trials. And in this trial, they were comparing a standard schedule of 66 gray and 33 fractions, but they were randomized to either get it in 5 or 6 weeks. And they did the 5 or 6 fractions per week. And so the 6 fractions per week involved treating on a Saturday. But what that actually meant was that they were accelerating the treatment. So then you can calculate what is the expected difference in the biologically equivalent dose between the 2 arms. First of all, we need to work out what the overall treatment times are. So for 66 and 33, that will be 6 weeks plus 3 extra days and because of weekends. And so this gives us a total of 40 days. If we do 6 fractions, now the overall treatment time becomes 5 weeks plus 3 extra days. And this gives us a total of 38 days. So we've now reduced the overall treatment time by accelerating in 6 fractions instead of 5. Again, we know that head and neck is a rapidly proliferating tumor. And so we have to put in one of these K factors for loss of the treatment. And so we're going to assume it's 0.7 gray per day, which means that for the longer treatment time, we're going to lose some dose. For the shorter treatment time, we're going to gain some dose. So what are we gaining? Again, this would be the calculation that we would do. Here would be the equivalent dose in 38 days overall time. This is the 45, the standard schedule. So we have the standard schedule minus 38, minus 45, and then times the loss for proliferation, or the gain in this case for proliferation. And so when you work out this equation, you then get 66 gray, which is the standard treatment. Now we're going to gain 4.9 gray because we've reduced the overall treatment time by just over a week. And so the accelerated schedule is actually now equivalent to 70.9 gray. So again, it's showing you how you can use the equivalent dose in 2 gray to work out how much dose you're gaining in this case, because you're delivering the treatment in a shorter overall time. On the right, it shows you that this is the real data from the study, that the 6 fractions per week were significantly improved local control. no real effect on overall survival. But also one of the downsides of accelerating treatment is here. You can see that the confluent mucositis was increased significantly in the accelerated arm compared to the conventional arm. So again, there's always this trade-off between gaining some dose for tumor treatment, but increasing normal tissue reactions. So there's a lot of stuff on this slide, but it's just to give you an idea of how to use the equivalent dose in 2 gray to account for an unexpected treatment gap. And so here's a colorectal cancer patient who's getting this what's called the Swedish short schedule of 5.5 gray in a week. The patient had the first 2 fractions as planned, but then the machine ran into a problem. No dose was delivered on the Wednesday. And in this case, the patient has to leave town after Friday. So we've got to work out how much dose we need to deliver on Thursday and Friday in 2 fractions to recover the dose that we're going to lose by missing that treatment. So first thing we do, we're assuming an alpha beta of 10 for the cancer. And we're actually also going to calculate, what effect the change in treatment that we do have on the risk of rectal complications. And we're going to assume a value of 4 gray for the rectum. So the first thing you do in this type of calculation is that you work out the equivalent dose that you would have given the patient if you given the final 3 fractions on Wednesday, Thursday, and Friday. And so this would be the calculation. Total dose, we will give 15 gray. This is the dose per fraction. This is calculating at 2 gray. And so we end up with the value of 18.75 gray would have been given in those 3 fractions. So now we've got to work out, if we're now going to give that 18.75 in 2 fractions, then what would be that dose per fraction, those final 2 fractions? Again, some mathematics here. This would be our equation that we need to solve. Again, it would come back down to a linear quadratic, and we would solve the linear quadratic. And by solving that, we eventually end up, those final 2 fractions would have to be 6.7 gray per fraction to deliver that same equivalent dose in 2 gray in 2 fractions. And what that means then is that the total dose now is actually going to be 13.4 gray in those 2 fractions. And that's less than the 15 gray that we were originally going to give. And that's now because we've gone to a much higher dose per fraction. And so we don't have to give as much dose to get the same effect. However, now that we're giving 2 fractions of 6.7 gray rather than 5 gray, how does that affect the risk of bowel damage? So as we said, alpha beta of rectum is assumed to be 4. And so now we have the equation where we're giving, first, this is the first 2 fractions of the 5 gray. So this is the Monday and Tuesday fractions that were given. And then we're going to add on then the Thursday and Friday fractions, which are now 6.7 gray. And so when we do this addition for the total dose over that week, it's now 38.9 gray. If we worked out what would be the actual dose if they were given the 5 fractions of 5 gray, then that would give us an equivalent dose in 2 gray of 37.5. So this is what they would have got to the rectum. Now this is what they are getting with that change in the fraction size. So again, you would have to consider, is this enough to really change the fractionation and maybe not do these 2 larger fractions, but try and space out the fractions over 3 days and give another fraction on the Saturday. So again, these are sort of decisions that clinicians have to make. But again, the equivalent dose in 2 gray calculations can help you understand, how much dose you're actually giving when you have to unexpectedly change a treatment.
Yes, and I'm sorry to interrupt you, Dr. Wilson, but I believe this is a great example of something that actually happens in the clinic. Because, for the Rapido trial that we use this schedule, it's something that sometimes this happen, right? You cannot always start a patient on Monday to Friday, but sometimes something can come up and you have those delays in the treatment delivery. So I think that this is something that we actually encounter. So it's amazing that you show that EQD2 can help us to understand what may happen if we increase the dose per fraction or if we have those delays. So I think that's something that we do find in daily practice.
Yeah, and there's actually been a lot of good publications recently, because obviously these sort of interruptions became much more common during COVID. And
Sure.
it was a large experience from a lot of hospitals, both Europe and over here in USA and the South, of, how do you accommodate all of these changes, because they were much increased. So I would sort of direct you to some of that literature on COVID and treatment interruptions. Again, a lot of work was done as to try and work out what's the best strategy, to make up for that gap of treatment. And obviously it depends on the type of tumor. For something like prostate, it's not a big issue because overall treatment time doesn't matter so much. And even maybe breast. But then for things like head and neck and lung cancer, obviously the treatment gap is much more important and needs to be addressed in some way.
Yes, thank you.
Dr. Wilson.
And you can do the same thing with BED. You could also use the BED formula to address this as well. Again, they're both going to give you sort of similar information.
We are also having a good question here from Tamana. She's asking, are we taking into consideration in the quadratic model that the cancer have different clones and the state of the cell, mitosis and the necrosis and all those factors?
The alpha beta or linear quadratic, it sort of takes into account proliferation, but it doesn't take into account anything else. It doesn't understand the tumor microenvironment, but the tumor microenvironment affects the way that the tumor responds. So, again, that's why the alpha beta ratio is just an approximation, and it's a generalization of the characteristics of all head and neck tumors. But as we know, they all respond differently. And so this is, as I said, it's the one shortcoming is that we can't get an individual alpha beta ratio, which really reflects the biology of that individual tumor. We're always making an assumption that it's going to be this value, this magic value of 10 or whatever. And so, again, that's where clinicians can come in with their own experience. And, some head and neck tumors don't proliferate as rapidly as others. I did a lot of work in my early career when we actually injected patients with bromidioxyuridine, a DNA precursor, and we could actually measure what we call the potential doubling time in individual tumors. And we did that in many, many tumors. And again, for every tumor type, there is a large variation in TPOT. Some head and neck tumors had TPOTs which were very long, 30 days. Others were just 2 or 3 days. So again, you can take into account some of that other biological knowledge. The mitotic index is a sort of indirect measure of proliferation. The more mitoses, the more cell division is going on. And so again, there can be other things that you put into the equation. This is really just giving you the overall picture of really what is happening when you drop a fraction or two and how you compensate for it. But again, it's going to be your own experience and knowledge of the patient and the tumor, which helps you make the right decision for that tumor patient.
Thank you, George. Go ahead, please.
Well, now we're going to just talk about how you convert equivalent dose in 2 gray to BED and vice versa, and how they work together, and the information you get from both of them. Again, the equivalent dose in 2 gray can be easily derived from the BED as follows. So this is our biologically effective dose that we've calculated. Convert that into equivalent dose in 2 gray. We then divide it by 1 plus 2 gray per fraction over the alpha beta ratio. And so this is, again, a simple conversion back to equivalent dose in 2 gray. And so what you can then just simply remember is that if the alpha beta ratio is 10, then the BED in gray 10, you would just divide it by 1 plus 2 divided by 10, the alpha beta ratio, and that would give you a value of 1.2. So you can simply convert BED to EQD2 by dividing the BED by 1.2 if the tumor alpha beta is 10. For a late responding normal tissue, where the alpha beta may be 3, then we would divide the BED by grade 3. So it would now be 1 plus 2 divided by the alpha beta of 3. And that gives you a factor of 1.67. So again, for a late responding normal tissue, if you divide the BED by 1.67, you will get the equivalent dose in 2 gray. So that's just a simple way of converting one to another. Let's look at a comparison. So for an irradiation of 30 fractions of 2 gray, again, that will give us an equivalent dose of 2 gray and 60 because it's 2 gray per fraction. If we calculate BED for a late responding normal tissue, it's going to be 100 gray 3. And for a acutely responding tissue with an alpha beta of 10, and this fractionation schedule would give us 72 gray. You can see that the tissues are all getting the same radiation dose. You can see that the EDs are different in those tissues for the same dose due to the different characteristics of how they respond, and that basically they're alpha betas. So again, emphasizing the importance of the alpha beta in determining effective dose that they're getting, even though they're being irradiated with the same equivalent dose. So just another one example here. Here we've got a combined treatment of external beam and high dose rate brachy for a prostate cancer patient. They're going to get 50 gray and 25 fractions of external beam, followed by 15 in 3 fractions of brachy over 5 days. Because it's prostate, we don't have to worry about proliferation. We're going to assume in this example that the alpha beta of prostate is 2. Again, there's a lot of controversy as to whether it's 1.5 or 3, or some people think it's higher. But we're going to use 2 here. And so calculating the BED for these 2 schedules, this is the external beam, 50 gray. This is the brachytherapy. We get 152.5 gray 2. When we calculate the equivalent dose in 2 gray, so obviously the first part is 50 gray. But now we're adding the brachytherapy where we're giving a higher dose per fraction. And when we combine these two, we get the equivalent dose in 2 gray of 76.25. Again, you can see that the effective dose is almost twice as high as the actual equivalent dose in 2 gray. And so this is where the confusion between these two come in. Which one is the most important to use? And I think that's a question that really is not been answered, that you tend to use these in different situations because you can see they're giving you different information. So both of these, BED and the equivalent dose in 2 gray, are all based on the linear quadratic model. And the linear quadratic model really describes the relationship between the total isoeffective dose. This is a little drawing that Lee made, and dose per fraction. And so the alpha beta ratio is really the shape of this dose response. And so when it's low, 5 to about 6 gray, it is characteristic of a late responding normal tissue. And so there's a rapid increase of total dose with decreasing dose per fraction. And you get this sort of very bendy survival curve. The alpha beta ratio is higher, so for early responding normal tissues and most tumors, then there's a less rapid increase of total dose with decreasing dose per fraction and a less curved response. So again, really all it's showing you is that these late responding normal tissues are much more sensitive to changes in fractionation and total dose than early responding normal tissues and tumors. Both of these formulae provide a simple way of calculating isoeffective radiotherapy schedules based on the LQ model. And again, the important thing is that the tolerance of these normal tissues really is dependent on the alpha-beta ratio. The basic LQ model is appropriate for calculating the change in total dose for an altered dose per fraction, but that's assuming that they're given in the same overall time. Late reactions, it's probably necessary to modify total dose if you change the overall time, because they're not sensitive to overall time, because late reactions occur way after the treatment. However, for early reactions, then, if you change the overall time, there's a very complex relationship between total dose and response. So hypofractionation is a challenge to all of this calculations, because in the old days, people delivered 2 gray per fraction because they weren't able to really deliver the radiation as accurately as you can today. And so, simple box plans were used. More normal tissues were included in the radiation field. And that's really why a lot of these calculations were developed, because of the restraints of the ability to focus the radiation on the tumor. However, with modern technology, hypofractionation has become much more acceptable because we can reduce the amount of normal tissue in the field. But as I said, in the old days, really it was the response of the normal tissues that limited the dose that you could give to the tumor. So one of the issues now with this more hypofractionation and stereotactic radiation being delivered is that the linear quadratic has a bit of a problem with calculating the effective dose or the equivalent dose at these high doses per fraction. And so we're going to talk about the problem, and we're going to talk about some of the models which have been developed to account for that. So this is a complicated slide, which I'm not really going to go into any great detail. This is a standard linear quadratic model. So remember that linear quadratic is just a fit the data. Unfortunately, the linear quadratic predicts that there's going to be a continuously downbending curve as the total dose increases. And what it's really been shown is that doesn't really fit the data, that there really isn't a continuously downbending curve. It's flatter at these higher doses per fraction. And so that's one of the problems with the linear quadratic, is that it may overestimate the damage that's being caused at the high doses per fraction, which are used in some of the hypofractionation schedules and stereotactic schedules. So the other model, which was originally developed way back in the 80s, was called the multi-target model. And this is a much more complex model than the linear quadratic. It takes into account several other parameters of the survival curve. The DQ is what's called the quasi-threshold dose, reflects really the shoulder of this survival curve. The D0 is the dose that's required to reduce survival to 37.5%, but basically it's just telling you the slope of this part of the curve. Again, the D1 is the initial damage or the initial slope. So there's a lot more parameters that actually go into this model. And that was really why the model was not really favored. It was much more complex to calculate, and there was really no mechanism behind it. However, what this model did do better than the linear quadratic was actually to predict this higher dose region of the cell survival curve in a much more accurate way than the linear quadratic did. And so I think we're going to have our second poll question. Again, you can see here that the linear quadratic is good, low around 6 gray. This multi-target model is good above 6 gray. So this is the question.
Yes.
And we have just talked about it.
I will launch the next question. Give me a second, just right now.
So the question we have is limitation of the linear quadratic when we're doing stereotactic radiation is it overpredicts the potency and toxicity of the schedule. It underpredicts the potency and toxicity of the schedule. Underpredicts of potency. No, it's actually accurate of prediction of potency, but over prediction of toxicity.
Okay, give me, I think we're going 30 seconds more. Por favor, todos los que puedan responder la pregunta, sería excelente para conocer su punto de vista. Estamos esperando por sus respuestas.
Alejandro, did you write this question?
Sorry?
Did you write this question?
I think it was Ben. It was, yeah, it was.
Okay.
Yeah.
It's a little bit confusing, actually.
Okay. Go ahead.
So the answer is that it's overprediction of the potency and the toxicity. So it's overestimating the amount of cell kill, but also overestimating the toxicity as well. Now, I'm not, as I didn't write this question, I'm not sure that the concept of toxicity is really described in what we've just said. So I think it's a bit of a tricky question to actually answer. Once if you overestimate the potency, which it definitely does, it's going to give you more cell kill for the same dose than the multi-target model.
So, George, in conclusion, what do you say? I mean,
well, the answer that Ben wrote was A.
Yes.
And I'm actually now thinking that might not be correct. I think it's a slightly confusing question because all we showed was a cell survival curve for a tumor. We didn't talk about what the effect would be on normal tissues. But again, I guess that if it's going to over affect, it's going to depend on the normal tissue, whether it's a late or an early responding normal tissue as well, as to how much it will overestimate toxicity. But it's probably right, but I think a little bit confusing.
We should check this question for the next sessions, for sure. I'm sorry for the participants to have tricky questions.
The answer should be A. So we again, I think because of the slightly confusing question, we've got a very diverse group of answers.
Yeah, of course. Sorry for that, George. You can continue.
Okay. So because of this uncertainty of the linear quadratic in over prediction for these high doses, then I think it has led to some clinicians being hesitant to adopt SBRT, even though it is efficacious and tolerated well. And so to address this, another model has been developed. It's called the universal survival curve. And it provides a much better approximation to the experimental survival curves in this high dose ablative range. But also it still uses the LQ model in the lower dose region. And so this is basically the cartoon sort of showing you the universal survival curve. The critical thing here is a transition dose. And at this transition dose, which is actually an asymptote of projecting this final dose response line back to the axis here, wherever this crosses the actual survival curve. So below this transition dose, then the LQ model is used to identify, to calculate effective doses and such like. But above this, then the universal survival model uses that more complex model of the multi-target model above this. And so this shows you then that fitting with the universal survival model gives you this curve. If you fitted the whole response with the linear quadratic, you would get this curve here. So again, showing you that the linear quadratic is really overestimating the amount of cell kill at a particular dose compared to the universal survival curve. So again, it's using two different methods at different doses. So the key thing then is to calculate what is this transition dose when you move from linear quadratic to multi-target. And again, this can be calculated knowing three parameters. So again, the DQ is this quasi-threshold dose. It describes the shoulder. D naught is calculated as the slope of this curve here. And then the alpha parameter. So alpha again is the initial response of the tumor. So you would need to be able to calculate these three parameters. And this allows you to calculate where then this transition dose occurs for this particular tissue, tumor, cell line, whatever it may be. So from this concept, another concept has been developed. And this is that once you go to SBRT or very high hypofractionation, then you're really moving away from the conventional BED and such like. So what's been developed is a different concept of the single fraction equivalent dose for SBRT. So if you're now giving an SBRT schedule here, there's 1, 2, 3 fractions, then calculating what the SFED, what would be the same if you gave it as a single fraction. And this is really quite equivalent to the BED. You can see this line here where we have an infinite number of fractions, low doses per fraction. It's giving us the BED, and then we calculate what a conventional fractionation schedule would be. So again, it's now working at these higher doses per fraction that really it might be simpler to compare this hypofractionated schedule to a single dose rather than comparing it to a BED. So again, that's a different type of concept now for SBRT. So again, there's obviously equations we can use to calculate this. The BED would be calculated by the standard BED below the transition dose. And above the transition dose, we would calculate using the multi-target model, which would be this. And now we want to calculate single fraction equivalent dose. These would then be the equations that we would have to use. So now we've got to incorporate the DQ, the D naught, etc., into the equations. And again, depending on the transition dose, the equation would be different. So I'm not going into the detail of all this. Again, it's just to show you that there are ways that can now be used to better calculate what effective or equivalent dose you're delivering when you're delivering a much higher dose per fraction than what we've been used to at 2 gray per fraction. But again, it requires more knowledge of the response of that tissue or tumor. And this just shows you some examples. Here we have 4 different SBRT schedules. Here we have 3 fractions giving higher doses, and we're reducing 20 to 22, 18 to 20, 15 gray in 3 fractions, and 30 to 34 gray in 1 fraction. So these are the total doses that are being delivered. This would be the single fraction equivalent dose. This would be the biologically effective dose, and this would be the equivalent dose in 2 gray. So you can see that as we reduce the total dose in these SBRT schedules, and we're reducing the effective dose that we're actually delivering to the tissue. And you can really see that once you get down to a single fraction, then the single fraction equivalent dose is obviously the dose that you're delivering. But now the BED is much reduced and the equivalent dose in 2 gray is much reduced. And so in general, with ablative therapy, more than 1 fraction tends to be important because it's actually very much dependent on the total dose that you're delivering rather than the number of fractions that you're delivering. And you can actually see it here in this graph here. This is plotting total dose in SBRT against equivalent dose in 2 gray fractions. You can see there's a linear relationship between them, and really there's not much difference between the fraction size, the different numbers of fractions. So the total dose is really the important parameter when you're delivering SBRT. Maybe 1 fraction is not as effective as giving 2 or 3 fractions. Like all concepts in radiobiology, they can be other ways of analyzing the data and getting the same results. And this was actually Jack Fowler wrote an article. He was very worried that people were using two different models to describe the response curve at these higher doses. And he actually then produced a much simpler model and a more biological one, in his opinion. And that was that really many tumors actually have a much higher alpha beta ratio than 10 gray. And it's been shown in oral cavity, tonsil, it may be as high as 20 gray. And if you just simply introduce an alpha beta of 20 gray instead of 10 gray into the linear quadratic model, you actually end up getting very similar curves to the curves that were developed in that previous slide by using two models together. And this would then be the difference in the survival curves. This would be an alpha beta of 10. And now you can see if you assume it's 20, you get this much flatter response to these higher doses per fraction. And so again, Jack was saying that really you don't have to go into the extra detail and calculating the extra parameters that you would need for the universal survival model. You can just make a simple change to the alpha beta and produce something that might actually fit the data as well. So again, just showing you that people always have arguments and differences about modeling. But finally, we're just going to go through some real examples of hypofractionation in the clinic. And we're going to talk about prostate, breast, and rectum. And we're going to start with prostate. So we're looking here at moderate hypofractionation. So standard schedule in many places is 78 gray in 39 fractions of 2.8 gray. What we are now going to do is how does this compare to 60 gray in 20 fractions? So again, prostate cancer is slowly proliferating, a low alpha beta ratio, so we don't have to worry about a time factor. Again, the alpha beta ratio usually quoted from 1.5 to 3 gray. The organs at risk will be the rectum and the bladder, and the rectum has an alpha beta ratio of 3 to 5, bladder 2 to 3. We're going to assume an alpha beta ratio of 1.5 for the prostate cancer, 4 for the average value for rectum, and then 3 for the bladder. And all are going to receive the same dose. So again, we're not need to worry about proliferation. So we're using the standard BED calculation. And so 78 gray and 39 fractions is equivalent to 182 gray to the tumor, 117 to the rectum, 130 to the bladder. And you can see this shows you that one of the reasons why prostate may be a good candidate for going to hypofractionation, because the effective dose it receives is much greater than the organs at risk. So you can see that the equivalent dose in 2 gray is the same to all of those organs at risk, but because now the prostate has a lower alpha beta ratio, it's actually then receiving more dose. And so this is one of the reasons why going to these hypofractionated schedules may be effective. So now if we look at the 60 gray in 20 fractions of 3 gray, you can see that the BED is almost similar. We're now reducing the effective dose to the rectum and to the bladder by this hypofractionation. And again, the equivalent dose in 2 gray, 77, so it's very similar in the tumor, but now we're reducing that in the normal tissues. So this is an example of how we can change and spare some of the damage by hypofractionation. This slide just summarizes some of the work that's been done with monotherapy with HDR. Again, we're not really talking about therapy in this lecture. What it's really showing you is the evolution of hypofractionation in 6 fractions to 4 to 3 to 2 and then to monotherapy. And again, showing you the prostate, the rectum, and the bladder, BEDs that they'll receive, and the equivalent dose in 2 gray. And again, it really shows that the main point is that maybe 1 fraction isn't as effective as giving 2 fractions of high dose brachytherapy. And again, because the total dose is increased with 2 fractions compared to the single fraction of 19 gray. But again, just examples of how you can calculate these parameters for these different types of schedule. This is an example, again, of moderate hypofractionation in breast cancer. This was the START trial over in the UK. They compared the standard fractionation of 50 gray in 25 with 40 gray in 15. Again, breast cancer is a pretty slowly proliferating tumor, a low alpha beta ratio, so no time factor. The alpha beta has been estimated to be about 3.5 gray. The organs at risk are breast related, induration, telangiectasia, edema. And they're assumed to again be actually the same alpha beta ratio as the tumor. And then heart is also at risk, and the alpha beta ratio for heart is shown to be lower at 2 gray. So if we assume an alpha beta ratio of 3.5 for the breast and the normal breast, and 2 for the heart, again using the standard BED calculation, 50 gray and 25 fractions. Obviously, for equivalent dose in 2 gray, that's what they're going to get. But for the BED, which is now obviously changed by the alpha beta ratio, we get 79 gray to the breast cancer and the breast, and 100 gray to the heart. When we go to hypofractionation, then the dose, an equivalent dose in 2 gray is 45 to the breast and the tumor, 48 to the heart, so we've lowered it slightly. The effective dose is now 71 to the breast and the tumor, and 94. So what's interesting here is that we have reduced both the equivalent dose in 2 gray and the biologically effective dose to the tumor, but in fact, the trial showed that these 2 schedules were equally effective. There was no significant difference in the overall outcome. So even though we've actually lost some dose here, it's compensated by other factors involved in the shorter overall treatment time that this trial was given in. Final example is really looking at and again, the Swedish group had been the drivers of what's called the short course, which is 25 fractions in 5 fractions, just in 1 week. And so we're going to compare that to the more conventional 50.4 in 28 fractions of 1.8 gray, which is more standard here in the US. So one of the issues is that rectal cancer, colorectal cancer in general, is rapidly proliferating. So we do need to include a time factor in this. Rectum cancer has alpha beta ratios of around 5 gray. The rectum itself is around 4 gray. So we're going to use these 2 alpha beta values. And then we're going to assume that there is repopulation, and that repopulation kicks in after 7 days. So this will be the lag period, and that we lose about 0.5 gray per day. These are estimates which have been made. So obviously with the normal rectum and actually with the short schedule, don't have to worry about proliferation because the normal tissue has a low alpha beta, so it's not going to be as important. And then the 25 fractions in 5 gray occur before this repopulation factor kicks in. But for the rectal cancer, given the conventional treatment, then we're going to have to make an allowance for this proliferation. So when we look at the data, so let's look at the conventional treatment first. So the BED, if we didn't allow for proliferation and assume there was none, it would be 68. But if we allow for proliferation, it's actually 48 gray. And again, the equivalent dose in 2 gray would be 49 without proliferation, but it's actually 39 when we account for this proliferation. And so you can see that when we go to the 25 fractions of 5 gray, that we're getting a BED of 50. And so you can see that's much more equivalent to this conventional allowing for proliferation. And again, similarly for the EQD2. Partly what this emphasizes is that Again, these two schedules have been shown to be pretty much iso-effective. So this really highlights that there is proliferation, repopulation occurring during this more protracted normal schedule. And this has to be accounted for. And when you do that, you get very similar BEDs and EQD2s, which agree with the clinical outcome in rectal cancer. So we have another Zoom poll. I'll ask
Yes.
one.
Hope this one goes better than the last one. So I will start with this one. Give me a second. Okay, I think now you can see it and everyone. Do you want to read it?
Okay, so when we're treating a head and neck cancer, the following is true. We use an alpha beta of 3 gray. The overall treatment time is not important. Repopulation is not an issue, or the overall treatment time is important.
Let's go for 1 minute to people to answer. Por favor, todos pueden responder el Zoom poll que aparece en sus pantallas. Estamos esperando la respuesta de todos ustedes. Vamos a dar 10 segundos adicionales. We're going to give them 10 more seconds. Oh, okay. I will finish. And there are a lot of people more answering. Okay. 5 more seconds. Okay. Here we go.
So the answer is D, which the majority of people were correct this time, which was great. I'm sure that some of the people who got it wrong is probably due to my translation or something I've said. But yeah, we would normally, as we said a few times in the lecture, assume the alpha beta for head and neck to be around 10 gray, a rapidly proliferating tumor. We know and that we can lose dose by protracting the overall treatment time. So overall treatment time is really important. And repopulation, the other two, repopulation is an issue. And again, it's been shown in head and neck cancer that there may be this accelerated repopulation that kicks in later during the schedule. So the answer is really that overall treatment time is important. Extending it really is a bad thing, as we'll lose dose or effective dose as more clonogens need to be killed.
Okay, George, so.
All right. So these are the final take-home points. So the LQ model describes the relationship between the total iso-effective dose and dose per fraction, particularly in the range of about 1 to 6 gray. But above those 6 gray per fractions, then really other models, such as a multi-target, a single hit model, may predict that high dose region better. That's quite important when we're looking at SBRT. The alpha beta describes the shape of the cell survival curve. And as we've talked about it really differs between early and late responding normal tissues and tumors. And one of the notable exceptions of tumor is prostate cancer. So late responding normal tissues have a low alpha beta, around 3. They have a very bendy survival curve. And so this actually puts them at greater risk of harm at higher doses per fraction. So again, as we've emphasized, that change in the dose per fraction has much more effect on these late responding normal tissues than early responding normal tissues. So their early responding normal tissues and tumors have a high alpha beta, a flatter survival curve, and so are less sensitive to fractionation changes. As we mentioned a few times, unfortunately, it's not possible to calculate alpha beta ratio for individual patients. And so we have to have assumed values, and these are derived from large clinical studies where fractionation schedules have been compared. But again, it's an assumption. So the BED concept is derived from linear quadratic. It's a measure of the effective dose between different schedules. So it's particularly useful for understanding the effective dose that organs at risk are exposed to when you change a fractionation schedule. The equivalent dose in 2 gray formula is a convenient way of calculating iso-effective radiotherapy schedules that are equivalent to what would have been obtained using a conventional 2 gray per fraction schedule. And again, sometimes it's preferable to use this because it's a more realistic estimate of the dose. And also, again, as we mentioned, that a lot of the tolerance doses that we know about for normal tissues are really derived from studies which were done at 2 gray per fraction. And so it's an easy way of relating a change in fractionation and tolerance of that tissue. So these are some references of the main points that we've talked about. I'm going to add the reference about alpha beta values. I'll forward that to the organizers. Here also are just some BED and EQD quadratic equation. This first one I like the best. It actually was developed by Jack Fowler himself, who really is the grandfather of BED. And so it's a very nice model for easily calculating these different parameters. And I think that's my final slide. And I'm just meant to introduce that next week, Dr. Indran Chetty from Henry Ford is actually going to talk about the physics for hypofractionation.
George, thank you for a terrific session. I think all of us have learned a lot from you. So thank you again for this session. Personally, I learned a lot. Also, I will give you a last question. What do you think when a patient lost a session? What do you think about giving to that patient 2 sessions in the same day?
Yeah, so again, that's one of the ways to solve a gap in treatment, is to do fractions a day, obviously with a 6 to 8 hour gap between those fractions. And that can actually be a very good way for some of the more rapidly proliferating tumors, because again, they're going to be affected by changes in the overall treatment time more than a slowly proliferating normal tissue. So again, I think going to 2 fractions a day is one of the best solutions when you have a gap in treatment of adenocarcinoma or a squamous cell. But again, you've got to be careful about the dose per fraction, because you're now going to potentially change the dose to the normal tissues at risk as well. So again, it's always important to look at what effect am I having on my organs at risk, and is that going to be acceptable, or can I change the plan to make it acceptable? But certainly, I think the best solution for gap in treatment is 2 fractions per day, rather than changing the dose per fraction to a much higher dose per fraction.
Thank you, George.